Hello and welcome to the Midwire News Podcast. We are in Barcelona this week for the 55th annual meeting of the EASD, discussing its highlights with a diabetologist, a GP and a nurse educator.
John Wilding, I'm Professor of Medicine at University Hospital Aintree and University of Liverpool in the UK.
Amrit Lamba, GP from Barnet, North London.
Lori Berard, Diabetes Nurse Educator, Clinical Research Coordinator from Winnipeg.
Starting at the child end of life then.
Yeah, so I went to some very interesting sessions yesterday on pediatric type 2 diabetes, not necessarily an area that I'm very familiar with in primary care, but certainly an area I can see becoming increasingly important as we start to diagnose patients at a younger age. And it's just fascinating to see how different they can present, and particularly worrying was the complications that are present at the time of diagnosis. And then how their management is so different as well. The session ended with quite an interesting small study looking at metformin with liraglutide as a treatment option for children, looking at not only controlling glucose but also weight concerns as well. So yeah, just very interesting, something quite refreshing, and certainly something that I think I can take back to my colleagues in primary care, just to make sure we're not forgetting about this particular group as we start to diagnose patients at a younger and younger age.
Yes, I think you're right that it is a very different sort of condition in young people, and of course the RISE study, which has been studying youth and adolescents and comparing them with adults, one of the things that shows is that firstly, in all people with type 2 diabetes, it's really hard with any of the current treatments to reverse the beta cell decline. But that's particularly a problem in children and young people. And I suspect, although I don't have all the evidence for that immediately, that a lot of that's to do with the fact that, of course, if you're going to develop type 2 diabetes at a young age, you're actually probably going to have a bigger genetic burden of disease susceptibility. And that's largely driven by genes that contribute to beta cell dysfunction. So of course, if you've got that bigger genetic burden leading to faster beta cell dysfunction, it's going to be even harder to reverse that process in young people than it is in somebody who develops type 2 diabetes when they're older.
I suppose the concern also is developing at such a young age, the number of years that they're exposed to such a high risk as well.
And we've actually we have some really good data in this entire area that's been generated out of Manitoba, because we have such a high incidence in our First Nations population, and so there's some really good work that's doing in terms of complication progression as well. So I think that it's something everybody needs to be aware of, because it is becoming a disease of all younger, or a risk for a lot more younger children than specific populations, which is what we used to think of. We don't necessarily think of the diagnosis. They don't present the same way, and we can't treat them the same way. So we have to be innovative and creative, but we certainly can't think of them as little adults. We have to be very careful with treatment modalities in this population. So.
Yes, and I went to a very interesting discussion session around using bariatric surgery as a treatment for adolescents in particular with severe obesity, and of course a lot of those would have type 2 diabetes as well. And although it is an effective treatment, it is quite a drastic way of trying to manage diabetes. But of course you have to have a lot of infrastructure in place to be able to deliver that in a way that is safe, so that you're using that intervention in children and adolescents who are appropriate for it. And they have to be certainly physically mature. They have to. There's a whole load of issues around consent and parental consent and making sure that is all correct. Often a lot of psychological issues. And although we've got some quite good data from observational studies like the Teen Labs study, which has followed people for 5 years, we really don't know what the long-term effects are. But of course the alternative, which is severe complex obesity developing in adolescence and then leading to all of the complications probably in early adult life, it may actually be worse than having bariatric surgery, which does seem to provide a lot of benefits in that group. But I think it's always going to be a very small group of people that are offered that intervention.
And do you remember where it was conducted, that particular work with bariatric surgery?
So most of the data is coming from the United States. The presentation was done by Lori Berard, who's from Sydney, Australia.
Yeah, and I suppose something really interesting you touched on there was that this is quite a unique group, not only for the reasons we've already discussed, but a lot of the psychological kind of factors to consider, somebody going through adolescence, a lot of the social implications, and it's just very interesting how we've got these different cohorts of patients, and it's a very mixed kind of population of patients with type 2 diabetes, each having their own psychological, social and physical kind of needs to be addressed, akin to elderly in a sense. Yeah.
But there's also the familial environment that goes along with that, because as you mentioned earlier, it's the genetic burden for a lot of these young children. They come from families where both mom and dad, grandma, grandpa, 6 uncles and aunts had diabetes, and so that there's a whole environment that we don't address, right? Mm-hmm. And that's breaking that cycle as part of, sort of part of the entirety of that population. Then you end up with subsequent obesity and the higher risk for diabetes or diabetes. Yeah. And again, there's a lot of other things that we have to think about in terms of being able to manage that effectively. So,
and I do think we're going to see over the next few years a lot of new data coming out with all of the drugs because at the moment most of the medications that we use for treating type 2 diabetes are not approved in children. Mm. But I do know that there's a liraglutide study that will present next year. And so there is going to be more data coming out around use of modern glucose-lowering drugs in adolescents, and that will, of course, make it a bit easier for physicians and other healthcare practitioners to support young people with type 2 diabetes.
Mm-hmm. Yeah, absolutely. So we talked about children. Yeah. If we go to the other end of the spectrum, did you come across any interesting sessions on older patients with type 2 diabetes?
So I was involved in the DECLARE TIMI58 trial, and there was some very interesting data presented in a subgroup analysis of that trial looking at the breakdown of people over the age of 65, and perhaps even more importantly, people over the age of 75 in that study. So the DECLARE study was a very large study, and there was over 1,000 people over 75 treated with dapagliflozin or placebo in that study. Of course, it was a cardiovascular outcome trial, so these were relatively high-risk patients, most of whom either had significant risk factors for cardiovascular disease or who had, about 40% of them had had a prior cardiovascular event. And what that analysis showed is that the benefits of dapagliflozin treatment in terms of reduction in heart failure, hospitalization, mortality were pretty much the same in the older population, which I think perhaps doesn't surprise people. But where there has been a biggest clinical concern, and in fact in Europe a limitation in the license which says we shouldn't be instituting dapagliflozin over the age of 75 because of concerns over volume depletion, renal failure and other adverse events. When we looked at the adverse events in the DECLARE trial, actually they were no greater in the older population than they were in the younger population. So I think we can be reassured that it is obviously within the usual constraints about using any medication, that there is no increased risk of using dapagliflozin in an older population compared to a younger population, and the benefits are still there.
But it also reminds us that age is not an appropriate cutoff anymore, right? Mm-hmm. So you could, we look about, you mentioned the labeling of being 75, yeah, over 75, and yet we can think of situations where there's higher risk population patients in their 50s and 60s. So it's really that careful assessment of people that really needs to.
And I don't think age should replace clinical assessment. And so actually thinking about frailty, and clearly I think most of us would be very reluctant to institute aggressive glucose lowering treatment in frail elderly people, whether they're just about managing in their own homes or even people who are in rest homes or residential care. I think for that, or nursing homes, I think for that group of people we probably have to be a little bit more cautious and maybe relax our glycemic targets somewhat, particularly if we want to avoid the complications of treatment, hypoglycemia being one of them. And I know that hypoglycemia is still a it's not just a problem in people with type 1 diabetes, it's also a big problem in either insulin or sulfonylurea treated people with type 2 diabetes. And sometimes we have to think about de-escalating therapy in older people with diabetes as they become more frail.
And that's a really great segue to, I spent a lot of time at this meeting in hypoglycemia, and actually one of the questions that was asked was the question about, why is the cost associated with hypoglycemia continuing to increase over the years, despite the fact that we've introduced all kinds of new therapies that theoretically have no hypoglycemia attached for them, specifically in type 2 diabetes. And one of the things that was, sort of brought to the forefront was this, target-based glycemic control that isn't individualized for people. And so are we driving more fragile, more frail individuals to hypoglycemia with more significant consequences because there's this overall, sort of A1C of 7% or less than 7%, and so that there's not enough de-escalation of therapy, to your point. But I think what I really, so I love hearing about hypoglycemia, how we're doing a better job, because it's so debilitating for people with type 1 or type 2 diabetes. And there's a lot more emphasis in the sessions that I went to is that it is not specifically a scenario that occurs with type 1 diabetes, that there's a lot of it in type 2 diabetes and the consequences of hypoglycemia in general. So beautiful lecture by Brian Freer on terms of the consequences, that what happens physiologically in the heart when hypoglycemia occurs, helping people to understand the dead in bed syndrome was something else that was discussed. Is it bradycardia? What's the arrhythmia that's occurring? And of course, with all the advances in all kinds of technology, whether it be continuous glucose monitoring or continuous cardiac monitoring, or there was some brain modeling that was looked at in terms of what could happen in terms of recreating hypoglycemic awareness in people. So much work going on in this area in order to understand it, to try to prevent it. And I think some of the most fascinating things were some of the new technologies. So learning about infrared technology in a device that will be available within the next few years, and also some of the innovations in terms of insulins and other molecules that will help to prevent hypoglycemia from ever occurring.
So this is the idea of a glucose-responsive insulin. Mm-hmm. So the insulin is only active when the glucose levels are high, and when they become normal, the insulin becomes inactive. I mean, that's a very exciting concept. I mean, whether it will turn into reality, we have to wait and see. But usually when these things, once somebody's thought of the idea, usually it's possible to make it happen.
I suppose one of the things that we have to remember as well for our wider audience is accessibility to these new technologies, exactly, which I think is a debate in itself. Mm-hmm. And so I suppose that still brings us back to the grassroots, I suppose, of ensuring that the appropriate patients are medicated in the appropriate way, and if they are frail, if they are at risk of having hypoglycemia, that we take actions that don't require certain technologies that may not necessarily be available to that population.
But if I think about the message in terms of hypoglycemia, especially in the type 2 population, which again in primary care is 90 or 95% of people are in primary care, I think that there's still a lot of work to be done to raise the awareness that hypoglycemia is a problem for those individuals, because they don't necessarily complain about it, we're not necessarily capturing it, we're not necessarily asking about it, and that the consequences, some of the work that's been done looking at what happened in trials like Devote and Leader that have been presented to show and that was, a lot of that was talked about, is the subsequent sequelae after having had a significant hypoglycemic event in terms of mortality. But I think a lot of people still believe that hypoglycemia is just a problem in type 1 diabetes. It's horrible in type 1 diabetes, and people with type 2 diabetes don't really get it unless they're on lots of insulin. So I think we're going to continue to really expand this area, and moving towards technology that is accessible for more people will help us with that story. But definitely grassroots, not everything's going to be available for all people.
Yeah, so my experience with people with type 1 diabetes is they found, the technology to be really useful, to prevent hypoglycemia. And patients who've who have particular problems with hypoglycemia, the CGM systems and the alarm systems can be really useful. But the accessibility and the ability to use this in type 2 diabetes, it's almost impossible to, I mean, certainly in the United Kingdom, it's not possible to get any of that technology for someone with type 2 diabetes unless the person pays for it themselves.
So it's good that they do research in that area, because then at least they can take a mass population and say it's actually happening. Will it lead to access? But it at least leads to information for people to actually be more aware. And the other thing that was talked about too was the area of hypoglycemic unawareness and some of the retraining that can be done, and how the systems help with hypoglycemic unawareness training, because the alarms are one part of it, and then sort of the education processes that still need to happen. Alarms alone do not take it away, but certainly they're a first step. So.
Yeah. Did they talk about the sort of some of the anxiety that can be created in that situation? Because people actually use these systems and then they can actually get over anxious about hypoglycemia because of the alarms going off all the time.
Well, and beautiful lecture yesterday on who hypoglycemia really affects. So the person who sleeps with the person who's on an alarm doesn't sleep well because the alarm's going off. There's so much fear of hypoglycemia in their loved one, fear for family and fear for the parents. So that there was that pro and con discussion about anxiety because you're going in that direction, comfort because you're aware that your loved one is going in that one, but anxiety again. So I think this is an area that will just continue despite all of our advances, which is, I think, so interesting. We've had so many advances. It's still a real problem for individuals. So that was good. I liked that one.
So moving on to advances in treatment, I know you were quite interested, Amrit, in the Verify study, which is kind of maybe a slightly different approach to early treatment of type 2 diabetes. You want to tell us about that?
Yeah, I'd say that I've sensed the overall theme of treating earlier in type 2 diabetes across the last few days here at EASD, and actually if we're looking at some of the newer agents, SGLT2 inhibitors and GLP-1 agonists, their role seems to be expanding as well, different patient groups perhaps benefiting. And so the flip side to that is, how do we implement it and when do we implement therapeutic options? So the Verify study looked at starting newly diagnosed patients with type 2 diabetes on a combined therapy of metformin and vildagliptin. So metformin and DPP-4 inhibitors complement each other quite well in terms of their mechanism of action. And perhaps as expected, it did show that having two therapies started together early is better than one, and in fact delayed treatment failure essentially in terms of A1C control. It was interesting because it identified a few other kind of areas that people weren't expecting. Some cardiovascular data as well came from it, although it wasn't powered to be a cardiovascular study. The numbers weren't high enough, and also we didn't have long enough trial for that. It did show that the group with combined therapy actually had fewer cardiovascular events over the course of the study than the monotherapy group. So that raised some interesting kind of thoughts, and also it identified the Asian group that were treated with the combined therapy. They appeared to have better glucose control as a result, and again that generated quite a bit of discussion about what's special in particular about this group of patients, and is there something about their beta cell capacity at lower BMIs as well, and there was a thought of whether having combined therapy at an earlier stage would preserve that beta cell for this population that can otherwise have quite kind of pronounced depletion. So it did raise quite a few interesting questions, but in terms of the primary endpoint, it was probably what we were all expecting, two better than one. But it does open the door, I think, for further studies in terms of combination therapies. There are lots of questions being asked about combining SGLT2 inhibitors, for example, with metformin. So that was very interesting, actually.
What about the sort of legacy effect they found in the effect on the time to secondary treatment failure?
Yeah, that was interesting as well. So even after having reached initial failure of initial treatment in the monotherapy group, when that group did have dual therapy, so the double metformin and vildagliptin therapy, they still found that those who were initiated right at the outset on the combined therapy had better glucose control durability than those who were added on later. So that was also very interesting as well.
No, that is fascinating data, and of course we are, the DPP-4 inhibitors are well-established treatment. We know they have a very good safety record, and it's quite interesting to see that when you combine them with metformin, there is at least a hint of cardiovascular benefit, although none of the DPP-4 inhibitors CV outcome trials have been able to demonstrate benefits. So we have to, put that in context. I think it's hypothesis generating rather than it's not going to change practice tomorrow, but it may help us.
And reminds us that the populations of people that are studied in cardiovascular outcome trials are not the newly diagnosed at risk, right? We always have the highest risk people in there. So maybe again, not that anybody's going to redo all those trials, but in different populations, different outcomes. And
the thing is, if you look at the long-term data from, for example, the diabetes prevention studies like the Da-Ching study, it actually took 22 years before they were able to show a reduction in cardiovascular events in those people who had the intervention. So, it may just be that our current cardiovascular outcome designs are really only designed as they are to show short-term benefits in really high-risk patients. And if we want to show benefits in a lower-risk population, we're going to have to think about longer and larger studies, which would probably have to be a completely different model of doing clinical trials. Data-enabled trials is one of the ways that you can do this, where you just randomise people and follow them up within routine healthcare systems. And I think that's a really exciting area for the future.
Couple of minutes, anything else that anyone wants to talk about?
I think we've come to a kind of natural close.
You all did a marvellous job of inventing your own segues, so I didn't have to keep coming in and moving things along. It's fantastic.